I request the chairpersons to kindly start the session.
Good evening. This session, the next part of the betting, very important topic that chronic diabetics having erectile dysfunction, how to manage. It's not only the management, it is the presence of erectile dysfunction, that means blockage in the penile artery. Is it a precursor to the blockage in the coronary artery also, or even in the brain arteries? How much atherosclerosis will be there in all the peripheral arteries if there is presence of erectile dysfunction in chronic diabetics? Let's listen to the first speaker. You can speak.
Yes, thank you very much. So may I invite the first speaker, Dr. Vineet Surana, for his presentation on 44 years gentleman having type 2 diabetes for 5 years, presenting with erectile dysfunction. So it's a very common scenario, and as the time passes, as the duration of the diabetes increases, as the age increases, actually the frequency of the erectile dysfunction increases, and the management become complex. So from the very early part of the diabetes, if a person is a doctor becomes, they're very careful and the question is there to the patient, then it's become very important and very effective in treating these cases. So may I request Dr. Vineet Surana to start his presentation.
Thank you very much, sir. Good afternoon, everyone, and very thanks to Dr. Ashok Taneja, sir, Dr. Satish Gulati, sir, Dr. Inderjit Prasad, and Dr. Naval Kishore Vikram, sir. So my topic is about the approach to a patient of diabetes coming to us with the erectile dysfunction, but I will kind of little bit deviate you first from that topic and then come back to the same, because it's not that every diabetic patient is having a erectile dysfunction just because of the diabetes. There can be multiple factors which may be playing, and we need to see the patient in toto rather than just focusing on that the patient is diabetic, oh then definitely he will be having erectile dysfunction, and the cause is only and only diabetes. So this is something which are the places where the actual erectile dysfunctions are being treated, because the patients really feel shy, and as a diabetologist and endocrinologist and the physicians, most of us never ask the question to the patient. Patients themselves feel little awkward in talking about their erectile dysfunction, especially when they are with their family members, and most of the time they are either being accompanied by their children or by the wife, and usually they don't talk, and we never ask that question also. So the first thing which we need to always ask our patients with the diabetes as a protocol, that whether they have any kind of sexual related issues or not, then only we can actually give them the proper treatment. So male sexual dysfunction is something which actually can be divided into 3 parts: erectile dysfunction per se, diminished libido, or it is an abnormal ejaculation. So I'll come to the first case. So this guy is a 39-year-old software professional, has got erectile dysfunction only for the last 2 months. He has been married for the 12 years, have 2 children, one aged 9 years and the 5 years, and as such he does not have any known medical condition. Now, what should be our approach to this patient? So we need to first differentiate whether it's a sexual concern per se or it's a sexual dysfunction. So many sexual problems are actually related to the life stress and the relationship issues, which actually none of patients come out with until unless we talk to them in details. And these actual issues are often very transient and resolved without medical intervention. So actually don't require any kind of treatment per se. And the sexual problems should be differentiated from the sexual disorders, which tend to be more severe and persistent, and they are the one which will require medical intervention. Now, The most important part, as we always have learned from our MBBS time, is the history, and more so with the erectile dysfunction. You don't have a very good test, very reliable test which can tell you that yes, this patient will have erectile dysfunction. So it's the history which will tell you the all stories. And ED is defined as the inability to attain and or maintain penile erections which is sufficient for satisfactory sexual performance. So we need to take two kind of history, one detailed sexual history and second one is medical history. So what is that? So first you need to find out the description of the erectile dysfunction, what is the age at onset and how long it has been. Is it is associated with any kind of a specific event. So even one failure in having this sexual relationship can actually lead to the psychogenic ED, and the patient will become more and more conscious about that and he will fail again and again. Then whether it is a rapidly progressive or it's a gradual dysfunction, what is the quality of erection, whether it's a partial erection or it's a kind of unable to sustain. And then frequency of dysfunction is mild, like it happens sometimes, moderate very often, and it's like a complete absence, so there is no erection at all. Now, in a setting of erectile dysfunction, we'll look at the presence or absence of any nocturnal erection is there or not, presence or absence of dysfunction with the different partners, presence or absence of dysfunction with the self-pleasuring. Because all these 3 points are very, very important, and that will tell you whether you are dealing with a sexual disorder or it's just a sexual concern. And then other sexual problems like loss of libido, ejaculation problem. And then we need to ask other medical history like any presence of chronic disease, something like diabetes, hypertension, use of prescription, OTC or any recreational drugs, and history of cigarette smoking, because that is one of the known factor for ED. Now, so in this patient, if we go back with the history, his onset is very acute, just 2 months back, sudden onset. It's an intermittent kind of erection and partial erection. He is having an intact nocturnal erection and the normal libido both, and he is able to self-stimulate and ejaculatory volumes are also normal. So that means it's more because of work stress, marital discord or performance anxiety. So how to differentiate between psychogenic versus organic, because this is something which is very, very important. Once you differentiate this, then the management is very, very simple. So psychogenic is something which is sudden, shorter duration, like in our case 1, intermittent function, variability and situational progression will be there. He will have a preserved nocturnal and extracoital erections. Psychosexual problem can have a long-standing history, and then the treatment is predominantly involves psychosexual counseling, which may involve our mental health care professional as well. It may involve even the partner also in that treatment part. Sometimes even PDE5 inhibitors can be given just to build up the confidence in the person. Whereas the organic causes will have a gradual, longer duration, they will have a slow progression, nocturnal and extracorporeal erection will be also lost, and psychosexual problem mostly will be absent or it can be secondary because of the disease per se. And in such patients, the treatment remains predominantly PDE5 inhibitors and the others. So once the patient is in ED, is self-reported, then we need to rule out medical and psychosexual history as we discussed, identify the sexual problems other than the ED, identify common cause of the ED, any reversible risk factor and the psychosocial status we need to assess. And then it has to be focused physical examination which involves any penile deformity if it is there, prostatic disease, any signs of hypogonadism, any cardiovascular and neurological status, and then test usually involve glucose and lipid profile if it is not done in the last 12 months, and the total testosterone morning sample if indicated. We can even go for the bioavailable or the free testosterone. So the most important investigation remain, rule out the diabetes, get the lipid profile done, get the testosterone done. Other can be based on the medical histories, thyroid function test, CBC, KFT or LFT, and if testosterone comes out to be low, we need to look at the LHFS and prolactin also to rule out that the patient does not, whether it is a central hypogonadism or it's a secondary hypogonadism, and also if there is a no existing prolactinoma, because that is one of the common cause for the ED. So in this patient, there is no apparent organic cause. There is improvement in the lifestyle and addressing stress for the psychogenic ED. This patient may be require a referral to mental health professional for the psychosexual counseling, and if needed, PDE5 inhibitors can be used in very selected cases. So listen, what we have learned from the case 1 is that it's a difference between we need to differentiate between the sexual concern and the dysfunction. We need to differentiate between the organic versus the non-organic causes of erectile dysfunction, and we may involve our mental health professional colleague also if it is needed, and PDE5 if at all we need to use, we use in a very selected cases. Now coming to the typical my talk, that's the 48-year-old male, BMI 28, diabetes for last 6 years and hypertension for 4 years. It is very well controlled. He is on the sitagliptin 100 mg, metformin 2 gram, telmisartan 80 mg, metoprolol 50 mg. Occasional smoker and drinker. His issues are that difficulty in maintaining erection for the last 1 year, and it's a kind of gradual progressing. So most likely we are dealing with a organic ED. Now how to approach these patients? We revisit the history, sexual history, libido is normal, nocturnal erections has decreased, it's a single partner, there is no relationship issues or performance anxiety. Medication history, none other than the medicine for the diabetes and the blood pressure, no history of any CAD, CVA, PAD, peripheral neuropathy or vision problems, and he occasionally goes for a walk. If we do the physical examination, everything turns out to be normal, and the investigation also suggests that other than the lipid profile in LDL being the 120, rest all reports are normal. So the treatment in this patient will involve push him more and more for the regular exercises. He should stop smoking, he should lose weight, and should be started on the atorvastatin 10 mg. And then he can also take the PDE5 inhibitor sildenafil 50 mg on demand after proper counseling, how to take it. So the major things which we need to remember when we are prescribing our patient PDE5 inhibitor is that it should be taken at least 1 hour before planned intercourse. Patient should have a light dinner and avoid oily food on the night of the medication intake, and no nitrate for the 24 hours after drug intakes. Now coming to the oral PDE5 inhibitor therapy, it's basically act by increasing the cyclic GMP by inhibiting its degradation, and it's need a relatively intact NO response to be effective. The contraindications are if the patient is on the nitrates or the significant CAD where the sexual activity is not recommended, and non-arthritic AION. So I'll just skip this because of time. So I'll focus more on the sildenafil and the tadalafil, two most commonly prescribed PDE5 inhibitors. So sildenafil may have an interaction with the food, as I told, less oily food, whereas the tadalafil does not have such thing. Onset of action is slightly delayed in the tadalafil, but the peak is by 120 to 240 minutes. So tadalafil actually being taken early as compared to the sildenafil, and the half-life is 18 hours. It can cause little bit of myalgia and backache, whereas sildenafil sometimes can cause minor vision problem. Efficacy wise, all three are equal, more than 65%, and there is some drug interaction with the ketoconazole, erythromycin, intraconazole, lopinavir, but not with our regular diabetic and the hypertensive medicines. So the side effect can be headache, flushing, nasal congestion, dyspepsia, myalgia, backache, and vision problems. So there is another school of thought which says, rather than giving on-demand therapy, why don't we give a drug on a regular basis, because we never know when the patient is going to have the sexual intercourse. So tadalafil, so this was the study which actually looked at the same concept, tadalafil 5 mg once daily, and they clearly showed that it improves the lower urinary tract symptoms and erectile dysfunction. And this meta-analysis actually indicated that 5 mg once daily to be an effective treatment for LUTS also, and as well as ED with low occurrence of the side effect. Now, what are the cautions which we need to keep with the cardiovascular disease, as Dr. Taneja sir also told in the initial time? The patient with the MI within the last 90 days should be avoided. Patient who have an unstable angina occurring during sexual course should not be prescribed. Patient who have a NYHA case class 2 or greater heart failure in last 6 months. Patient who has got an uncontrolled arrhythmias, hypotension or uncontrolled hypertension. Patient who had a stroke in the last 6 months, and patient with the left ventricular outflow obstruction should not be prescribed any of the PDE5 inhibitors. So there are some drugs, there are concern that they can also cause some amount of some amount of erectile dysfunction. So what are the drug of choice can be in patient who comes with the ED, ARB followed by ACE, and calcium channel blocker for the treatment of hypertension in patient with the ED should be the preferred one. And then beta blockers are something which can actually increase the ED frequency and the severity of the ED. So there was a data which suggested that when the patients were switched from the beta blocker to nebivolol on the erectile function of the hypertensive patients, and they found that benefit of nebivolol was better compared to the metoprolol. So the lesson learned from our case 2 is that diabetes and vascular disease are the common causes of erectile dysfunction. So any patient who comes with the organic cause, 25% are having the diabetes and 33% are having the vascular disease. PDE5 inhibitor is something which should be considered. Patient selection is very, very important, and then timing, stimulation and avoiding fatty meal is key to effective result, which is not with the tadalafil per se. And organic ED in absence of other causes can be considered as a possible marker of the CVD. So what about the CVD? All men with unexplained ED should have a thorough evaluation for CVD. Any risk factor for CVD that are identified should be addressed. The Q risk group incorporated ED as an independent risk factor into their updated 10-year cardiovascular risk model, and the presence of ED conferred a 25% increased risk for the CVD in an average middle-aged male. So what are the meta-analysis? So this was a basically umbrella review of systemic review and the meta-analysis. So it was a meta-analysis of the meta-analysis, and where they found there was a consistent increased incidence of the cardiovascular risk. So whether it is the CVD or the cardiac heart disease or the CV mortality, which shown that it has increased in a patient with the erectile dysfunction, predominantly CVD and the CST. So what is the common link between these two? So cardiovascular risk factors leads to the inflammation, atherosclerosis, same way low androgen levels, endothelial dysfunction, which is a known fact, atherosclerosis, and ultimately erectile dysfunction and coronary artery disease. So ED is common, especially with the advancing age. ED and CVD share the same risk factors, have a common pathophysiological background. It's a highly prevalent in the CAD patients. It's a marker of generalized vascular disease, and it's precede a CVD event by 2 to 5 years. So actually when the patient is coming with the ED, you can actually predict their CAD also, and we need to be little bit more aggressive and finding out their CAD. And then it's predicts the cardiovascular events and all-cause mortality as well. And the patients with intermediate risk factors needs further evaluation of the CV risk and should be included CVD risk reduction also. So sexual inquiry of all men, that's very, very important. So all the patients coming to with the diabetes, middle-aged patient, we should always ask a history of the ED. Once the ED is confirmed, look for the exercise ability. If it on exercise ability he is at the low risk, we advise and treat the ED only. If he is at the intermediate risk, then do the stress test. If he pass, then he is a low risk, just to treat ED and advise about the better lifestyle modifications. Stress test, if he fails, it's a high risk, or if the exercise ability is also very poor, then high risk, we need to refer to the cardiologist for a better management of the CED and evaluation. So this is another case scenario. He is a 42-year privately employed gentleman, sedentary lifestyle, has a family history of diabetes and the CAD, already established CAD. Weight is 96 kg, BMI 34, blood pressure 136/90. His fasting is 114, A1C 6.3, well controlled. However, he's got dyslipidemia and NFLD. Now, he has got an ED which is progressive for the last 8 months. When he was further evaluated, testosterone was found to be 188 nanogram per dl, which is clearly low. His LH and FSH were 2.1 and 2.9. His TFT, prolactin, cortisol were normal, so suggesting of a hypogonadotrophic hypogonadism, not very common but not very uncommon also, especially in the middle-aged and the patients who are coming beyond 50 years of age. So there are few things which we need to take care in a patient with the testosterone deficiency. Never take a sample in the evening, otherwise most of the time you will get a low testosterone and I will label them with a low testosterone. It should be taken in the morning sample before 10 a.m. Repeat test to reconfirm. You should have a 2 tests which suggest that there is a low testosterone. There has to be there are actually different cutoffs in different studies, but mostly we say if it is less than 250, it should be considered that testosterone is low and need further evaluation. If symptomatic for hypogonadism, we need to replace in absence of the contraindications, and should all cases of low testosterone should be replaced. That is something which is controversial. There is no clear-cut guideline what should be done, but if there are symptoms, we should definitely treat them. So, the learning point from the case 3 is that functional hypogonadism is very common in obesity, diabetes and other metabolic disorders. Hypogonadism is something which should be ruled out if history is suggestive, and the patient will require testosterone replacement plus minus PDE5 inhibitor. Most of the patient actually becomes very well with the testosterone replacement, and if fertility is concerned, then SCG and FSH injections should be considered rather than replacing them with the testosterone, because fertility can be negative in such patients later on. So, I think I got the time. So, evolution and treatment of men with erectile dysfunction, I will just take you through the overall picture. So, take a history, taking physical examination, lab test, do the assessment whether it is a clinical significant findings or they are not. Patient and partners goals and preference education should be done very clearly. Then look at the sexual physiological and pathophysiological counseling and diagnostic and therapeutic options, which has to be a shared decision making. It can't be, okay, you have a ED, just take this PDE5 inhibitor, you will be well. No, it never happens like that. It has to be involved with the partner and has to be discussed in detail what is their goal, what they want. And then whether it is a hypogonadism, your job is very, very easy. Just do the androgen therapy, they will be very happy. And if it is a complex problem, then you need to refer to the specialist for the evaluation and treatment. And shared decision making will involve modify lifestyle, change medications, and then if there are cardiac symptoms, do for the cardiological evaluation also, and then do the oral therapy. If they are dissatisfied with the results, or patient does not want any PDE5 inhibitor, or they have already used it by OTC, then you may refer them to the urology department also, which is like vacuum constriction devices, transurethral therapy, intracavernous injection. And if they are again dissatisfied with the result, then the option remains penile vascular surgery or the penile implant. So, the take home messages are distinguish organic versus non-organic erectile dysfunction. That is the most important thing. It is a risk factor for cardiovascular disease. You need to rule out the diabetes, dyslipidemia and the hypertension if the patient is not a known case of same. Use PDE5 inhibitors when appropriate and very judiciously, but the timing and appropriate patient selection is very, very important, otherwise we fail, and we need to rule out the testosterone deficiency as well, and we will replace when it is necessary. So, thank you.
Thank you, Dr. Vineet. You have covered the topic very, I should say, excellently well. I have one comment to make. The CAD patients, especially they are having chronic diabetics, if they are, does not mean that they cannot enjoy sex. They can have sildenafil, but there have to be certain practical, very elaborative testing before they go for further this penile therapy and other PPD inhibitors. But one practical thing to do is ask the patient to climb upstairs. If the patient can climb 30 stairs comfortably without much dyspnea, it is very safe to give sildenafil in that patient. But if it is 20 to 30 stairs, you have to be cautious. And if it is less than 20 stairs, then certainly absolutely no to these sildenafil derivatives.
That's very true, sir.
Another very important point in diabetics is to do Kegel exercises, that is pelvic floor muscle exercises to strengthen the pelvic floor muscles. That enhances the erectile function. And these are the two comments I wanted to make.
Thanks.
Thank you.
Thank you, Dr. Taneja, for your comments. I think the topic has been very well explained by Dr. Vineet. If there are questions, I think for lack of time, we can have one or two questions. Yes, please.
In the situation of CAD, what Dr. Taneja said very well, one more suggestion, where we cannot give sildenafil or tadalafil, and patient is a case of coronary artery disease. There is one drug which we use in coronary artery disease is nicorandil. This drug is very useful in these cases. It improves here, it also improves that side. So, and doesn't have that adverse effect of tadalafil or sildenafil. Nicorandil, commonly known as Nicoran.
Thank you, sir.
I think the most important drug is your psyche.
Yes, that's the most important thing, and we need to
See,
rule out
if
that.
if you want to go to bedroom, first reading Ramayana, I think there is no use. So psyche is the most important thing.
There is one fashion nowadays to check for free testosterone.
Yes.
The country who are lacking in mass spectrometer machines, do you advocate testing this free testosterone?
No, we don't even look at the report. We mostly look for the total testosterone. Of ED.
Since sugar was high, he was okay with the sexual. Once he started having a lower sugar in the evenings because of sulfonylureas.
Low means it's a hypoglycemia or normal?
Sir, hypoglycemia kind of, because its sugar used to come after dinner, say 100, 95 or 106. This erectile dysfunction started.
Yes.
I thought that maybe sulfonylureas and sildenafil may be interacting with each other. So I had to change sulfonylureas because it was causing maybe a little lower sugar. So I'm not talking about hyper, I'm talking about hypoglycemia and erectile dysfunction.
Sir,
And interaction of sildenafil and sulfonylureas.
so I'm not very much aware of sildenafil and sulfonylurea interaction. So, but then what I think is, जब शरीर में ताकत ही नहीं है तो
आगे क्या
sex
करेगा?
कैसे करेगा बंदा?
Hypoglycemia, I think, will be the more contributing factors towards erectile dysfunction
Yes.
rather than sulfonylurea.
Yes.
Don't give glycerin
And
chloride
there is
in the
another thing.
night.
He used to have alcohol, sulfonylureas and sildenafil.
Alcohol itself is a big.
It's a big contributor to the eating.
Alcohol also causes hypoglycemia at times.
Yes.
See, alcohol is something,
I think we should go to the next speaker.
yeah, just one comment. Alcohol, one thing is said about alcohol, it increases the desire,
Takes the
but it
performance.
takes
decreases
away
the
the performance.
performance.
Yes.
So that one should always keep in mind.